Good morning, everybody. I must say that MPN and pregnancy are of increased interest and also concern because MPNs are diagnosed earlier and more young patients are now diagnosed in reproductive age. Also, the trend in the Western countries is to start late the first pregnancy, and last but not least, the better management of the illness and the improvement in quality of life with newer therapies has pushed patients in osing more and daring more, and pregnancy is one of the normal thing that you would do in your life, and is becoming more and more important. But there's a but. Of course, MPNs have an increased risk of thrombosis and hemorrhage, and so pregnancy and those two things are kind of complicating a normal pregnancy evolution. We need to control illness also during pregnancy, but therapies can be dangerous to normal fetal development. So we need for more information and recommendations. What do we know so far? There were approximately 1,000 reported ET pregnancies, less PV, 150, and for myelofibrosis, there were only sporadic reports. I think that no more than 20, 30 cases are present now in the literature. We have problems with fertility? No. It seems that there's no reduced rate of conception in patients either of male sex or female sex in conception and pregnancy, even during treatment, but there is an increased abortion rate as expected. We are talking about approximately 30% versus a 12%, 10%, that is the percentage in the general population. What about pregnancy? What are the problems with pregnancy? We already say that there is a higher risk of thrombosis, especially during late pregnancy, during the second or third trimester, not too much in the first one. There is also a problem in the postpartum because there is an increased risk of both hemorrhages in the first part of postpartum, 2 to 4 weeks after delivery, and thrombosis that is a little later. The risk is around 6 to 8 weeks after delivery. So how do we manage all this? I would say that the management must start a diagnosis. It is important to introduce the subject, to not have surprises, or to not have patients that don't dare asking or that are depressed because if we don't address the subject, it's probably because this is something that is going to be prohibited. So it's important now that we know more and that we have a little more confidence on this subject to bring up this thing at diagnosis. And the first thing that we need to consider is the fertility evaluation. So it is true that for men it's easier because you can go ahead and do a cryopreservation of the semen. In the women also you can proceed with oocyte harvest, and this is important because nowadays the diagnosis is becoming compared to 20 years ago, 20 years earlier, meaning that with all the molecular testing and the diffusion of the preventive medicine, you can diagnose those patients very early. It seems that the onset is now dropped around 40 years, while 20 years ago the median age was 60 years. So 40 years, we are still talking about reproductive age. It is important to manage pregnancies and also all the situation in those patients in a multidisciplinary team that involves, of course, some dedicated OBGYN that knows about the illness and knows what to search and what to fear. And also the medical assistant team, if a medically assisted pregnancy is planned, is important to follow also the pregnancy with those colleagues. And it's important also follow up of baby and mom after delivery. What about therapies? Therapies should be addressed in prevention of thrombosis and hemorrhages that are responsible also for the intrauterine growth retardation and some baby problems. Pregnancy status helps in reducing the number of platelets and HCT values because of the increased blood volume and the concurrent reduction of those values. But how to balance? Because if a patient has been treated already, treatment should not stop. Prevention of thrombosis and hemorrhages include the use of ASA, basically, and also of a low molecular weight heparin, depending on the risk that you are facing. It is important that each pregnancy must be considered individually and possibly in a team. Speaking of those illnesses singularly, in ET, interferon can be used to cytoreduct if the patient is already treated or if you need to treat the patient during pregnancy, because interferon is quite safe during pregnancy. We have experience not only in hematological diseases, but also in non-hematological diseases. Interferon is slightly different, but the mechanism of action is very similar. ASA and low molecular weight heparin if there's a high risk. Polycythemia vera is a little more complicated because it presents a very, very high risk also in pre-diagnosed of developing thrombosis. And polycythemia vera should be absolutely treated during pregnancy. Also here we have the combination of ASA and low molecular weight heparin, but interferon is an important arm that could be used and should be used also because it controls the symptoms that sometimes develops during not only during pregnancy but are connected with polycythemia vera. Very little cases are described of myelofibrosis. If on therapy, just do not stop the therapy, whichever therapy we are talking about, to not have the rebound of stopping a treatment, especially if this treatment is working. And also here the treatments must be switched to interferon and evaluate the possibility to control thrombotic processes. What about the new molecules and drugs? We know that JAK2 inhibitors have been the real breakthrough in those illnesses in the past 10 years. And JAK2 inhibitors are TKI. The most data on TKIs comes from the chronic myeloid leukemia anti-BCR-ABL TKIs. The risk is more evident during organogenesis because of the risk of teratogenic action of those drugs. Those drugs are not genotoxic or carcinogenic, but can be teratogenetic. So certainly never use TKIs during organogenesis, but we don't know about the crossing placenta of JAK2 inhibitors. There are some TKIs that are used for CML that can cross the placenta, and those cannot be used even in later phases of pregnancy because they can interfere with other processes that are not only organogenesis. In vivo ruxolitinib studies on animals that are the ones that are most known did not find any drug-related adverse finding in pups other than low birth weight, and consider that usually the rats are administered double doses of the one that are usually used in humans. But since there are no information, we certainly suggest at present to switch to interferon if patient is treated with a JAK2 inhibitors and is planning a pregnancy or is on pregnant. We don't have any info on the newer drugs. What we know with other drugs, hydroxyurea is a carcinogenic drug, and is a drug that can harm the DNA because it's an alkylating agent. So it is certainly contraindicated in pregnant and lactating women. It is true that inconsistent results have been published on fetal and infant adverse event. Most of them are coming from the sickle cell disease patients. Some anecdotal patients with CML or also MPN were reported. We would generally not use hydroxyurea also because of the problems in formation of placenta. Different is the case on interferon, because interferon is not only is not only being used already in many type of pregnant patient, but also seems to facilitate the flow at placental level. It was not reported to be associated with fetal loss, even if used in the first trimester, and exhibits anti-proliferative activity on a variety of cells, inducing also a block of thrombopoietin megakaryocyte growth. However, it is not suggested in first-line intervention in patients with ET or other MPNs, but I think that is the only drug that we can consider to be used in this kind of group of patients. So throughout the world, through European Leukemia Net and in different countries, we are suggesting now the possibility to collect databases with information on patients, both female patients, but also male patients that are a little neglected. Probably there's no problem, but certainly there's nothing on literature than one paper on 20 male patient treated with different drugs with MPNs that were reporting on 30 pregnancies. So it's a very limited number of information that is reported. And we encourage everybody to connect with me or other investigators in harvesting information on either female and male patients during treatment for their outcome and management of pregnancy in MPN, so that this can be something that more and more will be incorporated in our routine practice.